One of the areas that's been really interesting around orals has been this question of adherence, compliance, persistence. And the numbers are kind of striking. In the order of breast cancer for aromatase inhibitors, it could be as low as 40% or 50% of patients are actually completing scheduled therapy for a minimum of 5 years. Now, the good news is 2 years may confer a lot of the benefit, but nonetheless, the studies are 5 years or more, and we've got 40, 50%. How do we fix the problem? How do we do medication therapy management? How do we improve the adherence around orals? I think that, for a long time, docs often stood their ground on orals. Granted, there weren't the number, but in the early days of capecitabine, for instance, with that, I know what my patient is taking. If the needle's in the arm, and I see the infusion, I don't know that when I give them pills to go home. And so I'm concerned about it, one, because you could have, to pay for a drug that's not being used. Yeah. In your case, to expect a certain end result and a certain outcome, but the drug's not being used. And it brings up both office dispensing versus specialty pharmacy-based medication therapy managements, which are often highlighted as a benefit. Although if you look at who's doing that medication therapy management, it may not even be a pharm tech, maybe a call center with unskilled labor. So it gets in a lot of questions here about that big picture of adherence, compliance, persistence. So I'll start with on the payer side. Is it a big issue and made a big issue by the pharmaceutical companies and specialty pharmacies because it's about dollars, it's about more drug being distributed, or is it a big issue because of the implications for the patient, and how does the payer see it?
Well, I think there are some conditions where we know that if you have poor compliance, your risk of healthcare consequences increase. For example, in CML, if you fall below a medication possession ratio of 80%, you're increased risk of accelerated blast phase. And so we monitor that because we know that there are adverse consequences. But I would say
monitor that. How do you monitor that?
We monitor that through the specialty pharmacy.
Okay.
And there's active outreach to the physician and patient if they fall below that. But I would say that's the exception. That's not the rule. I think for as much as people don't like health plans knowing their business, this is an area where we haven't been any more aggressive about promoting compliance than, say, for example, hypertension or hyperlipidemia management. I think that the fundamental issue is that we know that patients aren't compliant, but do we know why? What resources do we have to assess why? Is it toxicity? Is it or side effects? Is it affordability? Are there other issues? They don't feel any better on the drug. So I think it's more than just identifying that they're non-compliant. It's trying to understand why and address those problems. And there's really no one who's tasked today overall with doing that.
I would say that obviously adherence and persistence is very important to the physicians. I mean, our job is to help the patients get better. So I think we have almost as much invested in the patient's health as they do. And so I think the practices really work hard to, one, educate the patients in terms of what the drug does, how's it going to impact their disease, and what are the expected side effects. Some patients quit taking medicines because they don't have any side effects and they think the drug's not working, and then other patients have terrible side effects and of course they're going to quit taking the drug.
Yeah.
So
and in neither case are they necessarily telling you.
Right. Well, but our job is to ask the right questions and find out. And so certainly.
So I want to interrupt you there because I want to know, how are you doing that? Is that only when they come in the office, or do you have a formal, after we give the script, I have a nurse call that patient, with it, in 5 to 7 days to do that follow-up? I mean, how structured is that process?
In our practice, it's very structured in that we have the patients come back in 5 to 7 days to see a provider, whether it's a mid-level or the physician, just to see, were they able to get the drug, are they taking it properly, and what side effects are they having? Because obviously, I think if someone's going to have a lot of side effects, you want to intervene early and make the proper dose adjustments so that the patient doesn't get discouraged or get into too much trouble with side effects that they don't want anything to do with the drug. So I think earlier intervention is helpful for helping and reassuring the patient that you're going to monitor things and you're going to work with them to make sure that they get the proper care.